Welcome everybody to this webinar organized by International Hospital Federation. Today we are in Belgium, and let me say some words about our guest speaker, Professor Mark Noppen. Mark was born in Belgium, and he is Associate Professor of Pulmonology at the Free University of Brussels. He is also CEO of the University Hospital, US Brussels, and he's an author of more than 44 peer-reviewed papers in international journals and book chapters. He is also a visiting faculty at the University of Lille in France, Montreal, Canada, Harvard, USA, Nottingham, UK, and Perth, Australia. We're happy to have Professor Noppen today with us. Professor, good afternoon.
Good afternoon.
Thanks for accepting this invitation. We are now ready. Please take a hand and we can start your presentation. Thanks very much. Go ahead, please, Professor.
Okay, thank you. Well, welcome everybody. The topic of today would be the issues everybody in healthcare faces today, worldwide, but also in Europe and in Belgium. And the next slide here, the next slide here shows, gives you a short summary of the drivers of healthcare and at the same time the inhibitors of healthcare. So as important drivers that stimulate growth on the demand of healthcare are globalization. As always, this example that few people know that, we had a big GM automobile plant in Antwerp in Belgium, which worked very well, was profitable, but had to close. And one of the reasons was that a large part of the profit made by the company went back to the US to cover the healthcare for the GM company. So globalization is a driver. Consumerism, the citizens change, the patients change in their assertiveness, in their demands. They become more clients than patients. Demographics, of course, increasing age and BMI, etc. And very important, diseases become chronic. Nowadays, you survive your cancer and you become a chronic cancer patient. You survive your myocardial infarction, you become a chronic patient. And then, of course, there's the technological evolution in personalized medicine, which increases budgets. At the same time, you have inhibitors. There's a worldwide budget crisis. So societies, governments, politics are questioning the priorities, where to spend the public money. Social expectations change, and healthcare itself has its own inhibitors that very much is still focused on the short term, on verticalization, siloization, and there's relatively little attention and money that goes to the long term, the preventive, the horizontalization of healthcare. And of course the fragmentation of information. There's a lot of data, but it's still in those vertical silos with the GP, with the hospital, with the specialist, etc. And there's little sharing of information. And there is the paradigm, the model of healthcare delivery that can be questioned today. So what we have seen the last decades is that with time, healthcare expenditure was on the rise, and as time went by, the slope of the curve got higher and higher. You see the US as an extraordinary example, but in every Western country you have seen the same trend. Let's say from World War II even before, till a few years ago. And this is important because this exponential relative growth of healthcare expenditure relative to the wealth of the nation has stopped. In Europe, we have seen until a few years ago that per year there was an average increase in healthcare expenditure or growth in healthcare expenditure relative to the GDP of 4%. Now, you don't have to be a rocket scientist to know that one day this should end or taper at least, and this has happened. And this is the USO figures of 2010, which were released last year, and which for the first time show that in Europe, 24 countries of the European Union, which were taken account, now we are 27, but 24, we saw for the first time since World War II a decrease in growth of healthcare expenditure. So in healthcare expenditure in absolute figures. So this, in my opinion, is a very important turning point in Europe, where you see that we have probably reached the maximal expenditure possible. Now, with increasing demands and increasing needs, this means that This, for the first time, means that we probably should go to a structural change, a paradigm shift in healthcare. And we are not the first to say that. Now, to give you some examples, these are data from the UK. You see the solid line where you see the expenditures on healthcare, and the dotted line is the income. And you see this divergence, this what they call the scissors of doom. And NHS has issued a program where there should be a gain of 20% in cost efficiency for the next 10 years, which is an amazingly large figure, and which means disruptive innovation, disruptive changes. The same example here in the Hollands, in the Netherlands, where you see in the solid line above, you see the incremental growth of healthcare expenditure in the Netherlands. The dotted line is what would be expected with a normal evolution of healthcare expenditure, taking into account the increasing age of the population. You see this incremental growth, and it has probably reached now its maximum. Now, if we talk about disruptive change in the healthcare model, is that possible? I think it is possible, because if you analyze the current situation of healthcare, there are some alarming figures, in my opinion. There are some deficiencies. And there has been some scientific investigation towards this. And you see that almost half of patients still today do not receive the evidence-based care. Up to 30% of tests and procedures and what we do is medically unnecessary. So there's a redundancy. This has to do with sharing of information, by the way. Up to 50% of what we spend in healthcare goes towards waste. In any other industry, these are figures that are completely unacceptable. But in healthcare, for some reason or another, it has been accepted for a long time that there is a lot of waste in the production of healthcare. And this is also very important. Up to 20% of patients during a lifetime, 1 out of 5 of us who is looking at this seminar, at this webinar, will be harmed by healthcare during the course of his or her life. And it costs a lot of money to correct this. And also, and every clinician knows this, there are large variations in quality and safety and activity of care, and which you cannot explain on a medical ground. And IBM has looked into this, and they have examined all services and industries worldwide, and healthcare is by far the most inefficient service department or production department or industry, if you want, which is out there. So there is room for improvement, and this makes me optimistic, because even with the budget constraints that we have and we face nowadays, I think there is progress to be made. Here you see some examples of these very large variations in medical practice. For instance, the number of hip implants per population in various countries. You see a factor 2, which you cannot explain on a medical ground. The number of knee implants, a factor 3 between countries, which are not so different. The cost, or the tariffs actually, not the cost, but the price, the tariffs that are asked for medical acts vary a factor 10, for instance, for imaging. And this goes on in every possible metric that you can imagine. You see huge variations in practice, which probably means that the ideal practice has not been found yet. Now, if you look at the situation, let's say the hospital situation in Belgium, you know, the hospital expenditure is a large part of healthcare expenditure in every country. Hospitals are very expensive, and the activity of the population which is treated in current Belgian hospitals, there are about 104 hospitals in Belgium, and based on the data which are available in the ministry, Portella has made an analysis of which patients are actually in our hospitals. And you see that if you make the sum up to more than 30% of the patients who are today in my hospital here actually shouldn't be there. We are an acute hospital, but 1 out of 3, and we are full, but 1 out of 3 patients who are actually now today in our hospital actually do not belong there, or should probably be better off somewhere else. So there is a poor fix between the actual hospital bed offering that we have and the usage of the beds. Now, this is not new, and it's seen in most countries, and it has led people like Michael Porter and Thomas Lee to make a very nice summary of the current healthcare delivery situation. And actually, what we see today is the consequence of an historic evolution and growth in healthcare organization. And we are still very much verticalized. We have in a hospital, I have a medical department, and I have a nursing department, and a pharmacy, and an OR, and a technical, and IT, etc. It's all vertical. And within medical departments, I have 44 vertical specialties. And this is how it has grown, but actually, this organization is not what the patient needs. It shouldn't matter to the patient how we organize a hospital, vertical or diagonal or horizontal. The patient has a problem or several problems and wants the best possible help. And so you see this siloed system, which is even by law even supported. I mean, in Belgium you have to give an analytical bookkeeping to the government of all these vertical silos. So this means that it's not the most efficient way on what patients need, and I will give you some examples. And it causes stress, of course, because if there's enough money, there's no problem. But if you want to make increased efficiency, safety, quality, and save money at the same time, you probably will need to rethink your organization. And this is what Porter concluded, that the days of business as usual are probably over, and I fully agree with this statement. So the theory of Michael Porter would be that the core of the business would be to maximize value. This is the new mantra. It's value-based healthcare, which actually is common sense to me. It's trying to achieve the best possible health outcome at the lowest possible cost. Health outcome, by the way, that matter to patients, not to physicians or nurses or hospital CEOs like me. And this is the real paradigm shift, is a change in attitude and a change in psychology of the healthcare organization, healthcare delivery. And we have to move away from a supply-driven healthcare system, which is this vertical system which is organized around what we physicians do, and instead of a patient-centered system which is organized around what patients actually need. And this is not always the same. And very important in a country like Belgium, but also in countries where the fee-for-service system in payment for doctors is still in place, is to shift the focus from volume and profitability of services to patient outcomes. Now, this is a shift. This doesn't mean a big bang or a revolution. This won't work. But in a system where hospitals and doctors, like in Belgium, are paid per act, it's a system where you cannot save money. I mean, if the driver is service delivery, which means fee for service, then you have to probably decrease the importance of the fee for service, or the weight of the fee for service financing in the hospital, and give other weights, for instance, outcome, quality, some chance. And this is what is happening worldwide, also in the United States, where you see a progressive shift from a volume-based incentive, healthcare incentive, to a value-based healthcare incentive. And there's some really quite important changes. The payment system should change. There should be a degree of reward for quality and reward for outcome. In a system like today, at our hospital, I am rewarded, and I'm a little black and white and a little too short now, but I am rewarded to perform bad medicine. I give you an example. This hospital is paid per CT scan that is being taken, that has been shot on a patient. So the more CT scans I take, the better I'm off. But on the other hand, the minister says, in this country, in Belgium, there is too much radiation for the patients. Of course, in a system where you are paid to perform radiographs and CT scans, the population is exposed too much to radiation. So at the same time, the minister says we should reduce the number of radiographs taken and CT scans taken. But I am punished if I do that, because I'm shooting in my own foot if I'm decreasing the number of CT scans. That's just one practical example. So there should be a shift in payment system and incentives. I should be rewarded to increase value for the patient, not to increase the number of CT scans. Also focus more on the outcome of a whole population. If people ask me, how is your hospital doing, Dr. Noppen? And I said, very well, we are full. I always feel bad because I would much prefer to say, well, I'm very happy because only half of my beds are filled with patients. This means that my population is very healthy, but I'm not rewarded if I would act on this, and so forth. So there's this change in paradigm and attitude which probably should increase rapidly. So Michael Porter gives some examples of what should be done. I'll focus only on one, which is the organization of integrated practice units or focused factories. This means focus activities around predictable acts in a hospital. An extreme example is a focused factory, which is an integrated health delivery system which is organized around a specific patient need. This is only one of the possible solutions which we are now working on in our hospital in Belgium, but there's numerous other examples in other countries. Now, where does this fit in the whole hospital organization? Can we do that for every patient? No, we cannot. And we cannot because the hospital is a very complex organization where actually you have at least seven small and medium enterprises in the same factory with different management needs, with different patient needs, with different managerial needs, but which are all performed by the same people, the same doctors, the same nurses in the same hospital. And this is why it's so complex. It is completely different to manage a prevention program as compared to a very complex tertiary care multimorbidity disease, or manage a patient with a hip replacement, a standard hip replacement, which requires very different modes. And you see the number of patients which are in all our small and medium enterprises. And actually, if you look at these 7 different modes, you see that if you compare it with industry, and you can immediately see that the management principles are completely different. Prevention is like managing an insurance business. You ask for a small premium and the profits are made much later. An emergency department is like running a fire department or an army. I mean, you have to manage the unpredictable. Whereas elective things like hip surgery, it's very predictable. It's Toyota Six Sigma, Toyota Management Production System. It's like a focus factory and so forth. So you see there are different modes in hospitals. It's all about organizing the production, and the shorter the lead time and the lower the complexity and the variability of the production, the more you go to a focused factory. Like, for instance, clinics that are focusing on prostate surgery or hip surgery or shoulder surgery or hernia surgery. And there are numerous examples. And actually, we know this since more than 50 years, that if you have a factory where you want to do everything, it will not be a good factory. So if you have a hospital where you want to do everything on a good way, it will not be possible. And in the industry, we know this since more than 50 years, whereas in medicine, now it's only now that we are thinking that maybe this idea of a general hospital that does everything is not so much a good idea. So here you see some examples of focused factories like COXA in Scandinavia, Scholdeis in Canada, Martini Clinic in Germany on prostate. And on the left side, you see this general hospital board. When you come into a general hospital and you see 45 medical specialties, you can question yourself, are all these specialties do they respond to the standards of quality? And And I don't think so. I don't think that is the future. And now in Belgium, in our hospital, we also have some of these focused factories. For instance, you see there on the bottom of the slide, CRG, meaning the Center of Reproductive Medicine, which is a huge fertility clinic in our hospital, but which we actually manage as a separate small and medium enterprise, like a focused factory with its own management system and its own financing and geographically isolated, if you want. And you see this, the success of these things, you see it happening. For instance, the COXA Clinic in Scandinavia and Finland is focused on hip and knee joint surgery, and actually the results are fabulous. You see 50% less revisions. It's almost 50% cheaper because of the volume effect. Patients are much more satisfied, and staff satisfaction is still quite high, but you need to retain those people. It's like a factory, so you need some kind of extra motivator for these. In our hospital, on this graph, you see the 44 medical departments of our hospital. On the x-axis, those who are to the right from the zero, they make money. Those on the left, they cost money. And this has to do with the reimbursement system in Belgium. So it's not the fault of these services. It's just like reimbursement is. On the y-axis, on top, a positive scale means that you have a good clinical reputation in terms of referrals of patients, international patients, if you have scientific production, if you have teaching programs, etc. And the volume of the bubble is the volume of money going in this bubble. So theoretically, you would say, I only want in my hospital, I want bubbles on the upper right quadrant, which of course is not possible, because you also need those departments which are on the left. So you have to find this equilibrium. But you see the red bubble, it's the fertility clinic. And we treat it like a focus factory, and you see immediately the results in terms of finance, in terms of reputation, in terms of scientific production, etc. And in terms of clinical outcome, because we obtain the best pregnancy results in Europe. And this is one example of how one might react on the challenge, on the challenges which are facing us. And here you see the number of pickups. It's more than 5,000 now today. So it's the largest single center artificial reproductive technique center in Europe, which attracts international patients. So these are spin-off advantages of these focus factories, because 27% of the patients coming, now it's almost 30% of patients who are coming to the CRG are coming from all over the world. Whereas for the whole hospital, it's only 3%. So you see the importance of having such very successful services, and which also means that we can export our knowledge, for instance, to the Middle East, where there's a huge fertility problem in Kuwait and in Abu Dhabi, where we have set up joint venture programs. So to conclude, I think that the classical all-around multi-purpose sub-regional hospital, I'm not sure that that's a sustainable model, because of the all the issues that we've discussed before. I think that we must consider to adapt the well-known principles in industry and service delivery in other domains than healthcare, and we should try to translate them more into our own system, healthcare system. Maybe we should limit the number of these. You cannot close, of course, all these general hospitals. Of course not. But we might reconsider the model. So we might limit the number of these complete all-round multi-purpose hospitals and design a hub and spoke phenomenon where you have these regional general hospitals and maybe some satellites around it with more focused factory activities. I think countries around the world are working on this, the Netherlands, Scandinavia, Germany. I think this might be a model also to consider in other countries. We might reassign some hospital functions to various locations in this hub and spoke and hub model. Also for university hospitals, it's the same discussion. We might make more collaborative efforts between big academic institutions. when I was working in the Harvard Medical System in Boston, there are three Ivy League hospitals: Mass General, Beth Israel, and Deaconess, and Brigham and Women's. And even between those very much top university hospitals, there were patient transfers in certain domains. So I really think that the days that one single hospital or one single academic institution can claim to be the best in everything these days are definitely over. And the system has to follow this, of course. You need adapted payments to organize this, adaptive incentives, and smart IT. Data sharing will be very important in the future, and we are working on this also in Belgium. Maybe outsource everything that is non-core activity and use industrial principles like economics of scale. I'm thinking about pharmacies, logistics, IT, lab imaging, etc. These are things that you don't need doctors and nurses for, but you must have them. So maybe you can organize it more efficiently and better and cheaper if you do it on a regional hub and spoke network model. But of course and I'm a doctor by training, so I'm very much aware of the sensibilities of what we are talking about here. So we must use our doctors and nurses as partners in this new model. You need engagement of those people, and you need therefore also to give responsibilities, but also ask for accountabilities. And really what we need to do is break down those vertical walls between all these departments and try to team up more in a horizontal way. And I would like to conclude with the simple wisdom of a simple doctor is that if you have a disease and there are 193 different possible remedies, probably no single remedy is the best. So every country has its own specificities. I don't think there is a holy grail solution for every situation in every country. But I do think that some general principles should be followed more in reorganizing healthcare. This is my last slide, so I thank you for your attention.
Okay, thank you, Professor Noppen, for your interesting presentation. I would like to remember our attendees that we are going to open questions and answers, and I'm sure Professor Noppen will happily answer to your questions. So we're going to take about 2-3 minutes. Put your questions. Okay. Yeah, please stop your presentation, Professor Noppen, and we are going to allow the attendees to enter in the Q&A. So please stop your presentation. I'm going to launch the Q&A session.
How do I stop
I can do it. I can do it.
You can do it. Okay, yes, perfect.
Okay. So yeah, we're going to take about 2-3 minutes to see if the people are interested in asking something to you.
Okay.
Okay.
Okay, so the question is how to teach managers to change old ideas and to move for a new focus. Now, this is the holy grail question. This is all about how to change behavior and change attitudes. So I think you need a few things. You need to work on both the left and the right hemisphere. If you talk about managers, there is a left hemisphere present. So you should work on why you would like to change things. Before asking them to change anything, is explain the context where they're working in. And then the idea is to have the people engaged in grasping those facts and figures and trying to change their own behavior towards what they've learned with their left hemisphere. And it is this switch which is so difficult. So there are various techniques. It's the simplest is talk to people and try to really engage them verbally, but this won't suffice. So I think you have to create an environment where managers also are rewarded for this new adaptive behavior. And I don't mean financially. In my experience, this does not work. So financial rewards or bonuses, it comes only on the 6th or the 7th place in importance in rewarding behavioral change. It is give the managers a new framework where they can do their job, and really give them the autonomy and the responsibility and the accountability. And I have the experience in our hospital that this is one of the most difficult things, because you have these intermediate layers of leading managers and leading figures, and you have to have everybody aboard. And I can tell you we are not there yet, far from it, but we are starting. And if you have a few success stories and a few early followers like our fertility clinic, it's really contagious, and people want to be part of successes. So this is, I hope, a short explanation of what I think is important in this.
Well, Professor, I think we have no more questions. Your presentation was clear enough and was really interesting. So if this is the case, we're going to put an end to this webinar.
Okay.
Yeah.
Okay.
On behalf of the IHF Secretariat, I thank you all for attending this webinar, and we wait to see you soon by the end of the month with a new guest invited. Thank you, everybody. Thank you, Professor Noppen, for this interesting presentation, and have a nice day.
You too.